presentation is on simulation modeling applications in the healthcare industry. The presentation will be done by Stefan Bengtsson from Sweden.
Okay, hello everyone. Thank you for inviting me here. And I've been asked to share a little bit about our experience when it comes to using AnyLogic and using modeling and simulation in the healthcare system in Stockholm, Sweden. So this was really the title given to my presentation, but I would like to expand it and give it an alternative title, because the way I, as an individual, and my team look upon simulation is in some context a little bit different than others look upon simulation. I see it, for starters, as a form of art, not a method, as you sometimes hear it presented. So therefore, I will try to explain a little bit on how we use simulation, how we look upon simulation, and I will probably show 3 or 4 examples of cases where we have used simulation in this Swedish healthcare system. And please, questions might pop up while I show any of the models, and please address them if you feel they address the specific model, address them when they pop up, and then we can take some questions at the end. These are some of the models that we run around with and apply in various ways and use in the Stockholm healthcare system. Today I will probably focus on the 4 that popped up and popped away there. For starters, I want to share a little bit about healthcare and the healthcare system, because that really has to be the baseline when we discuss modeling in the healthcare industry. I have a background from other industry. I've been running around in most types of industry. I run around in the transportation sector. I've been running around in the service sector. The last 4 to 5 years, I've been running around in the healthcare sector. And what strikes you as different in the healthcare sector is that you have so many conflicting perspectives in the healthcare sectors, more than in most other industries. And that's an important aspect also when you use modeling and simulation in the healthcare industry. To start with, the organization of Sweden, we have 3 levels. We have the national and state level, we have the county level, and we have the community level. It's the county level in Sweden that's responsible for healthcare. And inside the county level, you usually discuss 3 types of roles. You have the ownership role, you have the purchaser role, and you have the provider role. Inside the county, you of course also have citizens. And these citizens are the ones with needs for healthcare. And the one who has already started to have these needs, that's the patients, the subset of the citizens with really healthcare needs. Then you have the politicians. And the politicians, as you probably know, and the healthcare system might look a little bit different in your countries, but really all these parts of the puzzles usually appear in some form in most healthcare systems. In the politicians' end, you have the majority and the opposition. In the provider role, you have the hospitals. And in Stockholm, we have both public and private hospitals. And all these hospitals, independent on whether they are public and private, they have their own boards with their own agendas. Then you have the medical centers, the general practitioners. You have various roles inside each caregiver. And you have various different clinics. So, where each clinic has different opinion on more or less any issue. And so on. Added to this complexity, I would say that you have the responsibility for elderly care, not in the county level, but in the community level. And you have the academic perspective, that's more on the national and state level. And all these perspectives are involved in healthcare. And they usually don't agree in more or less any of the relevant issues that we run around when trying to address in the healthcare sector. And that's part of the challenge, and also part of the challenge when we start using modeling and simulation in this context. So if we try to describe the healthcare system, it can be done in many ways. This is the way I do it. The healthcare system consists of many processes of different kinds. And the processes, that's the part of the system where we can achieve efficiency, effectiveness, if we do it the right way. The healthcare system also consists of a whole bunch of various types of resources. And it's with the help of the resources we can achieve capacity in some form. But it's first when we combine these two groups of entities that we are able to achieve what's really important, and that's what you usually call effective capacity. And you have a tendency in the healthcare system to focus very much on the resources and the capacity end, not realizing that to be able to get effective capacity that really matters, you have to just as much focus on the process end. And that's really a focus that's created by culture, by tradition, by competence, and many aspects. This system has to handle patients, send them into the system, and out comes, hopefully, in some form, healthier patients. This system usually, at least in the major counties, have to handle some kind of an educational mission, sending in potential healthcare personnel and getting, hopefully, healthcare personnel in the end, and researchers. And usually when you are a university county, you also have some kind of a research mission, sending in needs for knowledge and in some form getting out research findings, which will be feedbacked into the healthcare system. All this is scrutinized, studied, always questioned from the public, from media, from the politics. And it's measured in various forms, in productivity measurements, in more quality and patient security measurements, in more waiting times and availability measurements, and also in patient satisfaction. And to say the least, to get all these things to go in the same direction at the same time, that's a virtual impossibility. And that is the challenge of the healthcare system. You can never, ever have one single question of importance when you will get all the actors to agree. So to add to the complexity, the inflow compared to the industry tends to be a very heterogeneous inflow. The inflow partly lacks an upper limit, because when we make the healthcare system more efficient, the need will rise, or rather the demand will rise, because the patients see that we can do more and then they ask for more. The resources in the systems are also very heterogeneous, because they are human in many cases, some of the most important resources. Some of these resources are fought for by several of the missions on the healthcare systems. You have the care mission competing with the educational mission, competing with the research mission. And this makes the planning to get the processes and resources to cooperate to handle a varying need quite a major challenge. So all this together with the fact that healthcare involves many different organizations, this makes this an extreme, I would say, the most complex systems that I have seen, and I've been around in quite a few industrial and various systems. And one truth, the word optimized was discussed a little bit earlier, and I always react when I heard the word optimized being used in healthcare, because I say that's a virtual impossibility. Healthcare systems cannot be optimized. They can be handled, prioritized, and balanced, but never optimized. Because what is optimized for one of these parties is not optimal for another of the parties. Decision-taking in the healthcare sector. And the reason I'm showing this is it affects how we use modeling and simulation. So I will come to that later. I would say that if we have some kind of view concerning how decisions are taken, we might take 100% rational decisions, and we might take 100% non-rational decisions. And this is a scale. I would say when it comes to medical decision and clinical decisions, healthcare is very, very rational. They are on the right end of that scale. When it comes to business, operational, those type of issues, healthcare is compared to other worlds quite non-rational. partly caused by the strong medical base and the strong medical competence that are found in this system, which in one way moves away the other types of competences that are needed in the system. And it's also caused by the fact that you have so many parties that are in conflict with each other, and it's hard to take rational decision in that type of context. So other industry I often found there, healthcare I would say, and this is a personal view, so you can quote me, but I can't prove it. So I would say, very simplified, a sketch of the competence and culture. You are very much in the healthcare sector, very much formed by the medical competence, the academical medical competence, and everything that's related. When it comes to general management, when it comes to operations management and those type of issues, it's a much, much smaller part of the pie. It should be smaller, perhaps not as small. So therefore, especially in healthcare, and here some of you might agree and some of you might not agree, but I very stubbornly always say that the role of adding value with simulation is the less data we have, the more value we can add from a relative point of view with the help of simulation. The more data you have, of course you can create simulations that produces better rational results that are easier to validate, but then you would also have a chance with other methods than simulation to produce quite relevant results. So I usually argue that you have this type of relationship, that we should use simulation even more the less data you have. And listening to all the presentation during the Winter Simulation Conference, I therefore silently react quite a lot when data and the problems with data are so much emphasized. Because I would say that the role of simulation is to help out with data, and the possibility is even larger without data, or with less data. So, if we look at all the possibilities to add value with the help of simulation, I would say that the part where some kind of an evidence-based approach is an option, that is one part of the possibilities. The part where rational value is produced through simulation is a much larger part of possibilities, but the part where more non-rational values are added through the model and simulation, that's the biggest chunk of the pie. I will skip trying to explain this clearly, but really with rational value I mean that the values of the output of the simulation is of better quality than would have been with an alternative form of method. And this, I would say, implies that to fully utilize the value-adding potential of dynamic simulation, we should see it not as a method, but rather as the art of drawing a dynamic picture of more or less any issue that lives over time. And that's what we are applying in the Stockholm healthcare system. And therefore, we run around on big projects, small projects, strategic level, operational level, all around the county, and are getting more and more attention by doing this. I usually use 3 types of logic to explain why we need simulation and what simulation can do for us. The first logic I use is I compare with something that's quite established. Some of you might know it, it's called the PDSA or PDCA cycle. And in the academic healthcare world, that's more or less the Bible how to look at improvements in whatever the context. And I usually claim that to plan something in the healthcare sector is quite hard because of the complexity of the healthcare sector. So if we apply only this method all the times, we will run around in this circle quite many times before we reach a result that's acceptable. So therefore, methods like modeling and simulation can help us every now and then. And if we have realized that we need this help, we start with some kind of a reality. We have concluded that we need a model. When we start using that model, we simulate. and the purpose for this might vary. We might want to visualize, analyze, learn, whatever. We don't do this one time, we do it several times. And when we have done it, we are ready to act. And by doing these steps, taking these steps in between before we act, we are hopefully gained us the possibility to move up to a little bit higher level of improved reality than we would have otherwise. So therefore I usually compare with prototyping. And I say that in the industry it's often it's taken for granted that we have a phase in the product development process that we call prototyping. I would say that in business development processes, the concept of prototyping should be as self-evident, and that's what simulation and modeling can give us under certain circumstances. And now I will show you the first model, and this is related to one of the major construction projects definitely in Sweden, probably one of the major in Europe today, building up a completely new hospital that's supposed to be state-of-the-art, close to where the Nobel Institute resides and the Karolinska Hospital in Stockholm. And this new Karolinska Hospital is growing up like a mushroom right now, being built in the center of Stockholm. I was asked as a consultant 2 years ago to jump in and help in this issue, and really the issue was to raise the understanding on how well the objectives and vision for this new hospital, how well they would lead to reality in 5 years' time that really provided acceptable healthcare for the investments made, roughly speaking. And that was, roughly speaking, the whole project definition I got from the customer end. And then it was up to me to do something about it with the help of modeling and simulation. And that led to this model that I will show you. And I will start it up here in just a second. So this new Karolinska hospital, it's supposed to, or rather that's still an open question, it was supposed to focus on high specialty care, the type of care where the patient needs the very top competence to be taken care of. This is the architect's view of what the new Karolinska Hospital will look like in the future. This is just a bunch of explanations of the model. And if we move on to the model, it in this case looks like this, and I will start it while I'll explain it. What I realized when I started to dig into this project was that the reason around this project that had been done in a bunch of reports involving management consultants had a tendency to focus very much on the separate pieces of the puzzle. You could read in a report several pages about the future emergency department at New Karolinska Hospital, perhaps 5, 6, 7 pages, and at the end it concluded that this part of New Karolinska will be able to handle this many patients with this capacity. And then we turned the page and a new chapter began, starting to reason about the operation theaters, with a conclusion at the end, and a new page starting to reason about the wards, and so on. And the danger with addressing an issue like this that way is, of course, that a hospital is a system by itself. If you start focusing on just one piece of the puzzle without trying to establish how that is connected to the other pieces of the puzzle, you will not be able to, in a good, convincing way, really say anything about what production you can handle in one of the pieces of the puzzle. So I connected them, and as you see in each of these pieces, this is the emergency department, this is operations, these are the wards. Here are the open wards when patients come to see doctors but leave the same day. Here you have x-rays and stuff like that. Here babies are born, and here you have a patient total. And in this model, we can play around with an infinite number of scenarios by varying the inflow to various parts of the hospital, varying the resource level, varying the times, and varying the decision-taking inside of the hospital. And then we press the button and get some kind of estimate what would the future look like given all this at the same time. And so here you see the production ticking on, and here you see the resource utilization and so on. A model like this is of course not the truth of how it will look in the future, but it's closer to the truth than the alternate methods that would be to put figures into Excel. And that was really what was done before. This model did not either really produce any amazing new fantastic insights. I mean, but what it did was that the things that many people had argued for years, the model kind of put the foot down and said, stop arguing, this is the case, this is a problem. And just because of the various groups and various opinions inside healthcare, the need for this is huge in many situations, because around a discussion table, people will never agree. So that means that models like these is a help in getting people closer together and understanding more what they are discussing. Is this evidence-based? Of course it's not evidence-based. Issues like this can never be evidence-based. And I used this model to moderate the discussion between the top directors in the county before the model was finished, before these figures really could say anything, because we hadn't put in relevant data here. But it still enormously helped the discussion, because we have packaged a complex issue in one and the same place, and we have made it visual. And that's really what I meant before with that the rational end of simulation modeling is a part that's important, but not, if you look at the whole potential of modeling and simulation, as important as the non-rational ends. And as a matter of fact, this model has moved on, so I'm right now sitting and leading discussions with modeling and using an updated model. So I'll just show it extremely briefly. And I'll jump over to it, and we have it. So I call this NKS 2012 to distinguish this from the NKS 2011 that we just looked at. And this model is really the same base logic, but we have raised the level of detail a little bit more. So what you do with models like this is often that you start with one model, and the discussion starts going, and then this discussion turns, and new issues pop up on the political agenda and on the management agenda, which means that you have suddenly to address new types of issues inside the model, and therefore you usually update it. I'll just read in one of the model scenarios. In this case, I decided, even though the logic as a base logic is pretty much the same, I decided to change the visual look of it to be able to distinguish it from the other model. It's really, as you see, more or less the same structure, but the ward end of New Karolinska, I have divided into several potential places to put the patients, because that's one of this is, for example, intensity care, which is in this unit, and here are various places to put patients that don't need the intensity care unit, but need other types of caregiving units. And what you see during the simulation is really the utilization and whether we have balanced our allocation of the patients in a good way, given these levels of freedoms to play around with. And in this model, we can also play around with the allocation alternatives. So here you see various clinical needs for the patient, so we can move around these clinical needs however we want to between these possibilities. And what really this is based on is quite a big Excel file where the scenario is described. So here a bunch of relevant parameters are divided into the clinical groups that really are needed to be addressed. And these figures I never fill in. I design the model. I tell the manager and the people what we need to address. What types of parameters do we need to address an issue like this? And then in this case, I sent them an Excel arc and I told them fill them in. And if you have the data, great. If you don't have the data, estimate. Because here we are discussing issues. These are the types of data you need to give an answer to issues like this. And if you don't have the data, well, you wouldn't have the data if you didn't simulate either. But the simulation takes us a step forward in the right direction. Let's see, I have 10 minutes until the break, is that?
Yeah, correct.
Okay, and I will move on a little bit. Any direct questions related to D? Yes?
Just one short. Is there any simulation or modeling in more detail behind this? Thanks. Behind the different units you show here?
No, in this case, it's not, because this is a hospital that doesn't exist, and it's still a matter of discussion how they will work in the various units. So what I did, I mean, I had quite a tight time frame when I had 1 month to handle the first model, so it was not really an option to dig too deeply down into the details of the processes inside. That could have been done, but in this case I don't think it would have added much value, because this is a typical case when we have a strategic issue with parts that we have quite detailed information about, but other parts that we have an uncertainty that's this big. So even if we had made some parts of it more detailed, we still would have had that uncertainty, and it wouldn't, in the end, added so much value to the results. So it could have been done, yes. In this case, I didn't, and I don't think it would have added so much value.
Another question?
I have a question.
I think there was a lady.
Yeah, you said that you are looking at the resource utilization in this model. So did you also respect the layout? So deciding where to put which ward or which department?
No, I did not. But of course, if you had a reason to dig down, and we are involved in those types of projects also. But in this case, a hospital that when this project started was a hole in the ground. And some of the layout issues were not even up on the agenda yet. So it wouldn't have been a possibility. This was just to take a look at the big picture and see how right or wrong are people thinking. The next step would be, in a good way, to dig down, and we are digging down right now into the emergency department of this hospital that doesn't exist. So a good issue, but not in this case, not in this model.
I saw how you deal with patients and resources of hospital, but you started with different perspectives like media, politicians, and so on. How do these perspectives relate to model? How can I see it, and what is the relation?
Okay. Well, this model is not shown right now to media. It's, or as a matter of fact, it's mentioned and it's been discussed for a year or two with the politicians, but it's not been shown to the politicians. It's used inside the county work, both in discussion with the hospitals and discussions inside the county council organization. I would say in the long run, My plan, my hope is to very much also have discussion with politicians, because politicians can't have the detailed knowledge of the issues they are taking decisions about. So every method that helps in explaining and making something complex more understandable is something good when it comes to the interface towards the politicians. We are not there yet, but because you also have to respect that not too many individuals should run around and interface with the politicians, because that would create a tough situation. So right now, we and I are not interfacing much with the politicians, but in the future, I plan to make that happen. I'm not there yet. Did that answer your question?
So, as I understand, the model is the some tool that you will use to talk with politicians.
Not with politicians, with decisions taker inside the county council organization that supports the politicians.
Oh, okay, I understand now.
Yes, and this is an organization of 550 individuals, and then we have all the hospital organizations and so on.
Any other questions?
I might add that I will show 3 more models, so there might be other questions also, but please take another one with this model.
I just wanted to ask if I understand it correctly. You mentioned earlier that simulation can help more if we have less data.
Yes.
I totally disagree with this, because in my opinion we are developing research models for the Austrian health system for a long time, and I think if I don't have data I can use also formalisms and make models on paper. I think we still cannot throw away the point that we use a lot of valid data, just to mention calibration, validation, and a lot of other things.
Yes,
Don't you disagree?
Yes, I do disagree. And as I said, that the reason I'm not saying that if we have data, that's excellent. But in most situations, in healthcare and in other industries, we have decisions that has to be taken specific dates. And those will be taken with what you have at hand at that point of time. So that means that if you don't do simulations, you don't have the data, well, then the decision will be taken on poorer on poorer grounds than it would if we, without the data, at least took the time to create a simulation model to understand the issue a little bit better. So that's really my point, that the value added is very much there with or without data.
I want to add a question. I totally agree with you that we can improve a lot of the knowledge.
Yes.
But I think, and what we introduced a feedback loop, because we think we need serving simulation to have a feedback loop to generate more data. But I think we have to see it in a whole system. So, for example, we introduced in Austria very big data, for example, for the health system and for the treatment, and we have to improve data-driven simulation. So I agree that at the moment we can do a lot also, and we have also very often less data, but I think in 10 years we should have go far beyond this.
I totally agree that there is a need for more relevant data to support the decisions we want to take. And I think we don't really disagree, but I'm saying that even though we don't have the data, we shouldn't pass on the opportunity to help decisions with the help of a method that can package the system perspective in one place. And that's a major help with or without data. That's really what I'm saying. So really this model, the system...
Stefan, just the last question. One more question.
Sure.
You're already at the end of your, or you continue?
No, I will continue after the coffee break also.
Okay. So far, just one question. Why up to here did you decide for AnyLogic? Have you made experience with other software, and what was the feature? Why you decided for that?
Good question. I started my career as a fresh Master of Science 1988. And then I was introduced to simulation through something called Simula and Demos, which is considered to be the mother of all object-oriented languages. So we did, as consultants, modeling work with the help of Simula. So that was that I had a background of always being able to do whatever I wanted in a model. That was my background when it came to simulation. Then I've been working in management positions and in industries for roughly 10 years' time, and then I moved back to simulation 2005. And then I reviewed the world market when it came to modeling environments with the background of Simula that I had. And the only thing that came close, I would say, was AnyLogic. Because it gave the total flexibility, and it had, even compared to Simula, added several layers of help through the libraries and the packaging and so on. So really, my demands from simulation modeling environments is total flexibility, and I can't find that in a good way in any other product. That was the reason. So already 2005 I decided on AnyLogic, and I haven't been disappointed since.
Well, Stefan, let's have a break right now.
Yes.
And then continue, okay?
Okay, good.
Yeah.